The choices abound, don't they? They've changed a lot. We had conversation about the classic bilateral orchiectomy. We have agonists that have 1, 3, 4, 6, 12 month. There are sub-Q formulations, intramuscular. There's an implant. We have a GnRH antagonist, which is available. It's a 1 month sub-Q. Generics availability. We'll talk a little bit about that. What's the future? Where are they? Volume versus value-based care, and the possibility of an antagonist oral, not approved, but what if? So what I will ask the panel we have a series of questions, and here are the rules. These are the rules for this quick 20 minutes. Each panel member can get 30 seconds. Audience members, Bill Carden's going to walk around with the mic. I encourage audience participation. You get 30 seconds. My job is to be arbitrary and completely capricious in my authority. The rules have been fully endorsed by the Grand High Exalted Mystic Poobah, which is E. David Crawford. All right, so here are the questions for the panel and the audience. Remember, we welcome the audience to participate. So is compliance a concern? And if so, why, in terms of the mode of administration? And I think when the compliance is, are patients showing up on time? David presented a really good abstract the other day regarding late injections. So let me start off, I'll go with this notion around compliance.
So I'm going to say that it's a small problem, not a big problem, and that we don't see it very often in clinical manifestation. So every return appointment says on or after and has the date on it based on what they were administered. And we really haven't, in my clinical practice, 20 years or so, have only had a few patients where that was actually clinically important.
So David Crawford, you heard what Cookson said. He says it's not a problem. He's saying that the late injections aren't a problem. How do you respond to that?
I think he's totally wrong.
I thought you would say that.
Back it up.
I thought you would say that. All right, Concepcion.
So I think compliance is mostly related. I think in bigger community practices, it's not a problem per se relative to the injection. I agree with what Tom and David said. Physiologically, it's a problem, but the reality is, from an insurance standpoint, practices are not willing to risk an injection if they're not going to get paid.
Well, we need to change that.
Well, David, I'm not arguing that. I'm just saying that that's the real world within community practice. They have a wheel. Your point is well taken with the physiology, but from an insurance standpoint and a group losing money, they're not going to risk it.
His 30 seconds is up now.
Yeah. Okay, Mike Lode, audience participant, love it.
Just a comment that in the era of second generation, abiraterone specifically, compliance becomes much less of a problem. There are data to show that your T remains suppressed on Abby alone, as I think many people know.
Okay, interesting. We'll get to the issue. That's an oral, interesting, as opposed to what's approved right now, or IM and sub-Q. Okay, second question, when and why check testosterone level? We've talked about this, but maybe there are some new attendees in the audience today. So the when and the why to check testosterone level. Tom, let me throw that over to you first, because I know this is a passion of yours.
Well, I just think everything seems to be going fine until it isn't going fine. And you need to make sure that the patient is getting as low as they can. Why would you not want your patient to be as low as possible? And if you have results which show, and I agree totally with what Dr. Cookson just said, I mean, we don't know if it's a clinical problem or not. That's because we don't look for it.
Yeah. So Mike Cookson guidelines, and then later Jim Moeller. Will be interesting to see what he says about NCCN, about checking baseline T and then follow-up T. What do you think about that?
I think the guidelines are going to say in the 3 to 6 month range, check periodic, so we get it at baseline, and we do check it when we check their PSAs. And again, that's another reason why I haven't seen this epidemic escape.
But could I ask the audience, how many people routinely check a testosterone on their patients on ADT on a 3 to 6 monthly basis? Hands up.
About half. Larry and Raoul. Larry, is there a pathway within your practice that everyone checks, or is it sort of physician's choice?
No, we, in our ATC clinic, it's every 3 months. These patients are usually coming in every 3 months to see us. They get a PSA, and we get a T at that time. Especially if you have a PSA that's rising, it's really mandatory that you get a PSA, testosterone.
Yeah, Raoul, we have a paper coming out, don't we? Do you recall that question when we asked how we voted in terms of checking baseline T?
You know, I think we recommended a baseline T before institution of ADT. I think we made the recommendation to certainly check at 1 month to make sure they were suppressed. I think what happens in most community practices, it depends upon if they are biochemically recurrent and hormone naive versus in the CRPC space where I think like everybody checks every 3 months.
Question here, then question here.
Follow up on that, the idea. So if you're checking your testosterone, a couple of scenarios, if you have somebody who has an undetectable PSA on treatment and you're checking the testosterone and it is, say, 40 or 50, are you just going to be satisfied with your androgen suppression? And then in the instance, if you have, let's say your testosterone is 60 and somebody is starting to, they're starting to break through maybe with some PSA creep on the follow-up, what's your course of action going to be with that information?
So maybe we get Lori Klotz to answer that, okay? So you start at ADT, the PSA goes to undetectable, but you check a testosterone and it's either A, 40 to 50, or actually 60. What do you do? PSA is now undetectable.
Yeah, so the PSA being undetectable is beside the point. It's not relevant. The point is we know the outcome is better if the testosterone is consistently below 20. And in my view, it's kind of the area under the curve. Like Dave and I argue about this all the time because in my opinion, there's no compelling evidence that the blips above 20, say, really make a difference. But there's now about 10 studies in the literature, they all show the same thing. So the question is, what do you do? Why aren't they suppressed? The only predictor for failure to suppress is age. Younger men are more likely not to suppress, and all you can do is change the drug. And sometimes they don't absorb, so they don't absorb sub-Q, they're better off with IM, or maybe they have something about the carrier or antibodies to the drug. So if they're on, if they're on Eligard, try switching them to Degarelix or to another LHRH agonist. And there's no evidence the antagonists get lower levels of testosterone as a whole than the agonists. They have other advantages, but better testosterone suppression.
How many testosterone assays are there, and are they equivalent, especially in lower values?
Okay, well, I think sort of the easiest default is to get mass spec. But even within mass spec, there's lab variability of upwards of 20%. One other thing I was going to say to ask Lori was age. You mentioned. Is there any correlation with baseline testosterone in terms of failing to suppress below 20? So, for example, we're all 50 years old, and mine's 300, yours is 1,000, and we get several ones, and they're fairly stable.
Flatter me, but no, there's no. I actually don't think anyone has looked at that, but I would predict that would not be relevant. It's not the level of testosterone; it's the LH pathway, and
right. Yeah. Panel, any other thoughts on that? Okay, all right. So for the United States, and we do have a rather unique market, right? So given the current volume-based model that we live in, which is a bit schizophrenic, right? We're always talking about value-based care, and the Kaiser Permanente models and Geisinger and other models are moving, and APM models are moving towards that value-based aspect. And so given this sort of tension between volume-based modeling and economic incentivization, how impactful is it regarding your androgen deprivation therapy drug choice? And I'd actually, if there are any non-US folks here, it'd be interesting to hear that weighed in too. Arturo Molino, I saw, was over here earlier, and anybody else, perhaps our European colleagues. So Larry, the economic incentivization, how important is that in ultimately making a decision for the entirety of a large group practice?
It isn't, but I mean, if you're going to put somebody on Degarelix, then they're going to be coming in every month. So you've got another office visit. If you extend those out, then you have less office visits. But I think they're pretty much equal in the cost when it comes down to it.
Okay, in academic centers, Tom and Mike, and what I've heard, maybe it's different for you both, but I've heard that oftentimes there is the economics behind the volume and the deal that gets struck. I could be wrong. How is it in your institutions? Do you offer your colleagues in the urology department a dealer's choice? Can they pick all the different ones, or do you go on a yearly basis and pick one based upon a contract?
Well, the hospital's taken over the cancer pharmaceuticals, and so we won't really have as much of a voice in it going forward, and I'm sure it'll be based on volume and contracting through 340B.
Tom?
We're much the same. I have regular battles over the antagonists with them, but now we've moved fairly over to them I'd say at least 60% of the cases, 70% are on the antagonists, because I went and showed them the differences.
Dan Lin, University of Washington. Sorry to kid, but
very similar to Mike Cookson. I mean, it's almost exactly the same. I mean, I think that in our big academic centers, it's going to this sort of model that Mike said, very much out of our hands. I mean, we can serve on the pharmacy committee and so forth, but the voice is different.
sure. So it's kind of gotten out of here. Anybody in a group practice here who wants to comment how you make the decision, which is still in your hands to make these decisions? Any comments?
Neal, I would say that for a lot of, I disagree somewhat with Larry, is that a lot of group practices they're going to offer an agonist and an antagonist, and because there's more choices on the agonist, they're not going to offer the whole menu, and it's going to be basically driven because of GPO contracting on tier pricing.
Yeah.
Because the reimbursement's the same.
That's my impression, and so there's a heterogeneity to that. Anybody from outside the U.S.?
I wonder if we as urologists, we're having these meetings talking about agonists and antagonists and a difference in complications, cardiovascular, between the agonist and antagonist. I wonder why we are not leading the way in talking about orchiectomy, compliance, cost, side effects, everything. Every medical person that's related that comes in my practice, they get the orchiectomy. Everyone else, they want the shots. The shots, it's the expense, and they're going up. And
Yeah.
why aren't we talking about that more? We're
Okay,
talking about all this.
just for time, great point. So David, that was brought up, David Crawford, Grand Poobah, that was brought up yesterday. Similar question, why not just do bilateral orchiectomy? It's less expensive. What about the efficacy? What about the concerns about psychological morbidity to the patient?
So, we all sort of grew up that we felt bilateral orchiectomy was the gold standard, right? So, we know that when the LHRH agonist came along, it was a choice. There were a whole bunch of moving parts, including income to practices and lots of other things that put that on the market. I don't think any of us thought that LHRH agonists, orchiectomy was a bad thing, except for the psychological irreversible. Now we've got data, from a couple studies that it's actually the worst treatment, which is kind of shocking for all of us.
Yeah. Okay, great point. Next.
But there are people that do not respond to LHRH agonists or antagonists. They have antibodies. There's something else. They're overweight. Occasionally you should do one.
Okay, next question. It's a two-part question. Drug-drug interactions becoming more and more of a concern in so many of our oncolytics, right? And historically, I think we've given that short shrift. So drug-drug interactions, is it a consideration for the choice of your ADT? And is mode of administration a consideration? So for right now, let's leave that to IM versus sub-Q. DDI, sub-Q versus IM. Larry.
I don't really think there's a big difference in drug-drug interactions between the different formulations. I don't know if any of you have seen that.
I actually thought that there was some, in terms of the agonist, relative to getting a more sustained suppressible level below 10 for one particular agonist versus another.
Correct. That's a paper that we're in the process of.
Mike or Tom?
I would agree with what was said there. There does appear to be a difference depending on which formulation you use. And I know David has a paper that we're getting ready to submit concerning that. I won't say any more about it, but that's... Okay.
Potential review by NCCN at some point. Mike?
Well, I think the comment was made in the back, but I just have so few people on mono injection therapy anymore, that I wonder if this is a historical argument as opposed to a, going forward argument.
Okay, so you say that because you're doing couplet therapy for MHSPC, your MCRPCs are on combination therapy of some type, so it just may be in your biochemical relapse or in your radiation patients who are getting neoadjuvant adjuvant treatment, right? So that's where that could be a factor. Okay.
Neal, there is a little bit of an art, well, if you're going to use an agonist, these depot agonists, because especially in the CRPC space, sometimes you're giving bone targeting therapy, you're organizing labs, you're organizing imaging. So if you can time all that so it's convenient for the patient, also makes a difference.
Okay, we only have a couple of minutes left. We only have 2 more questions, I believe. Any safety adverse events of interest which differentiate your choice? IM, sub-Q, agonist, antagonist. Audience, faculty, no safety or AEs of interest. What about the injection site discomfort of Degarelix?
That's a significant factor. That's one of the reasons that a lot of the patients actually switch. It's a 30% plus injection site reaction at the initial injection, which has been lowered if you give a deep subcutaneous injection.
And what about just IM and sub-Q in general? What's your gestalt about tolerability, leaving Degarelix aside? But those are great comments, Tom. Does it make a difference, IM or sub-Q?
Well, it makes a difference among our nurses. Some of them prefer an IM injection, the others do sub-Qs. And I think that a sub-Q is probably less painful, but again, I think it's up to our nurses to decide.
Audience comments, Lori?
So the first dose of Degarelix is 2 injections and a larger dose, 240 versus 80.
Right.
So the injection site reaction is really much more a feature of that first loading dose.
Yeah.
And then the other thing, if the drug is injected over 1 minute, the drug is injected over 1 minute rather than over 5 seconds or whatever, the site reaction rate is a lot lower.
Yeah. Okay. Jonathan Henderson?
So having the option of a sub-Q and an IM is, I think, a bad choice for our clinical staff because the pharmacokinetics vary significantly for each preparation if you deliver it correctly. And it's not always that simple for a nurse to get IM when there's a large layer of sub-Q tissue, which we have a few of in the South. By the same token, it's not uncommon for an IM injection to be injected superficial to the muscle, and that drastically alters their absorption rates.
Yep.
I think the big thing changes when we get an oral antagonist.
Okay. Great point. And so that's a great lead. Let's skip this last one because I think we asked about this. And then here's, I'm going to even allow for reimbursement to come into this next question. What if there was an oral medication available? And let's assume that the oral, regardless of it being an agonist or an antagonist, let's assume it was non-inferior in terms of efficacy. What are your thoughts about a daily oral administration, making it simple, 1 pill once a day, food, no food, doesn't matter?
Changes the dynamics because of the insurance, because you're moving from Part B to Part D.
And what is, elaborate on that.
So, if it's an injection or infusion, it's basically buy and bill by the office. If it's going to be an oral, it falls into pharmacy benefits, and then you get co-pays, you get, there's a lot of things that change the dynamics for the patient and the practice.
Okay, so economics could be part of it. What do you think about patient compliance, Larry?
Well, that can be an issue. I mean, if patients miss a few doses, their testosterone is going to go back up, but, it's got a shorter half-life. In the trial, we have those little smart caps to remind them. But I think that out in the real world, how they're going to have to be more compliant and make sure they're taking it every day.
Final comments from Tom, then Mike, and then I think our time is up.
I would agree with what was said. But I do think the option of having a once-a-day pill has to be very attractive. Most of these guys, I would hope, if they're on their own and they've got a little bit of memory loss, that might be a problem. So you have to try and recognize that, I suppose, and not put them on that. These agents will still be available for long-term injection, etc. But I think as regards not having to have an injection or not having to have either sub-Q or IM, I think that's a huge advantage.
Okay. Mike, final comment.
Well, I'm probably biased because, like you, I was involved in the trial and I read the quality of life information that patients reported. I think they preferred the pill, but there will be issues with compliance, I think, harder than the injection because you know when they miss and you can hunt them down and get them. You don't know when they're out there not taking their pill.
But it could give you flexibility, though, especially if you want to tout more intermittent therapy.
Yep.
Definitely.
Okay, so I think it's kind of what I thought what we wanted to get out of this session, this particular case was we're taking an old therapeutic paradigm of ADT, T suppression, and still realizing in 2020 that there's a lot of different aspects and controversy regarding choice selection. So, gentlemen, thank you very much.